الكورليشن مع بقيه الانفستيجيشن اللي عندي. دلوقتي الدكتوره مروه هتتكلم على ازاي بستخدم الالكتروفيسيولوجي في السادن لوس اوف فيجن due to optic nerve disease.
Good afternoon. It's a pleasure to be here today. Thanks, dear Professor Wageha and Dr. Abdelshafy. Thanks, Dr. Wageha and dear Professor Abdelshafy for your kind invitation. My topic today is about electrophysiology in sudden vision loss in neurophthalmology. Electrophysiological tests, including visual evoked potential, are crucial in evaluation of sudden vision loss that may involve the retina, optic nerve, or the visual pathway. These tests are an objective functional test that can help to localize the site of pathology. In cases of sudden vision loss, VEP is essential to diagnose cases of optic neuritis, ischemic optic neuropathy, or compressive optic neuropathy. Also, it's useful to differentiate between optic nerve and cortical causes of vision loss. The VEP, it measures the electrical response from the visual cortex after visual stimulation, and it can assess integrity of the optic nerve and visual pathway. The VEP originates mainly from the visual cortex, so it reflects the function optical retinal neural processing of the entire visual pathway from front of the eye to back of the brain. The difference between VEP and other diagnostic tools is that VEP is functional test that assess visual pathway integrity, while OCT is a structural test evaluating retinal nerve fiber layer thickness, and both are complementary in neurophthalmology. The clinical VEP is mainly dominated by activity from the central visual field, the macula, and this is because the macula is represented by a large cortical area posteriorly near the scalp where the VEP positive electrodes are placed. When we need to assess the prechiasmal function, we use a single recording channel with midline occipital active electrode 2.5 centimeters above the anion. To assess chiasmal or post-chiasmal function, and additional multiple electrodes sites are recommended. According to the stimulus, there are three types of VEP: flash VEP, which use flash stimulus; pattern reversal VEP, which we use alternating white and black checkboard stimuli; and pattern onset offset VEP, which is less commonly used, but it's useful in cases of nystagmus and malignant. The flash VEP is useful in cases of medial opacity in infants or where there is poor patient cooperation, but it's less sensitive to the effect of the disease than the pattern VEP. The pattern VEP is more sensitive for detecting optic nerve and visual pathway disorders, and it requires an adequate level of fixation and compliance. When we analyze the pattern VEP, we mainly concentrate on the implicit time and amplitude of the P100 wave. The P100 wave is the key component of the pattern VEP, and it represents conduction through the optic nerve to the visual cortex. The normal latency of the P100 wave is about 100 milliseconds plus or minus 10 milliseconds. In the waveform interpretation, where there is delayed P100 latency, think about demyelination. A prolonged P100 latency is a hallmark of optic neuritis and is often associated with multiple sclerosis. In cases of chronic demyelination, like neuromyelitis optica, may also have a prolonged latency and reduced amplitude. If we have a reduced amplitude, think about axonal damage. Low amplitude means that there is an axonal or cell loss. So, if P100 amplitude is reduced and latency is normal, suspect optic neuropathy due to ischemic optic neuropathy or Leber's hereditary optic neuropathy. Some diseases can cause a change in both amplitude and implicit time, and these diseases not damaging only the nerve sheath but also damage the auxiliary fibers, such as compressive optic neuropathy or toxic or nutritional optic nerve dysfunction. In unilateral cases, suspect optic neuritis or compressive optic neuropathy or ischemic optic neuropathy. In bilateral VEP abnormality, suspect demyelinating process or toxic or nutritional optic neuropathy or hereditary optic neuropathy. The comparison between the two eyes is very important. Asymmetry between the two eyes more than 10 milliseconds is highly indicative of unilateral optic nerve dysfunction due to optic neuritis or compressive lesion. The clinical applications of VEB is essential in diagnosis of all types of optic neuropathies. Also, it's useful to differentiate between functional and organic visual loss. In cases of malingering or hysterical blindness, these patients will have a normal VEB in presence of reported severe vision loss. Also, in assessment of visual pathway integrity in children and nonverbal patients, we can assess the visual acuity approximately by using SWAB VEP in young children or using different sizes of pattern stimuli in adults. We need to order VEB in cases of sudden vision loss if the fundus is normal but vision loss is significant, or when the MRI is normal or unconclusive, or when we suspect functional vision loss, or to monitoring recovery or efficacy of treatment in case of optic neuritis or trauma. Now I will present some clinical cases for demonstration. This 20-year-old female patient, she has a sudden diminution of vision in right eye, pain with eye movement. The fundus is more or less normal. The MRI brain was unconclusive, but the pattern VEB of the right eye here, the P100 wave is marked delayed. And even the asymptomatic left eye also P100 wave is delayed. When we have abnormal pattern VEB, we have to do the pattern ERG to detect any macular cause of this abnormal VEB. In this patient, the pattern ERG is normal, so this confirms that the patient has a right optic neuritis. So in any case of defective vision, always correlate between ERG and VEB to differentiate between optic nerve dysfunction from maculopathy from generalized retinal dysfunction. Another case of 30-year-old male patient with bilateral diminution of vision, vision 0.2 in both eyes. The brain MRI with contrast revealed multiple foci of abnormal signal intensity due to demyelinating process. The pattern VEB is delayed P100 wave with preserved waveform which suggests demyelination. The pattern ERG of the patient in P50 is well formed and with selective reduction of N95 in keeping with retrograde degeneration of the retinal ganglion cell. So in cases of optic neuritis due to multiple sclerosis, up to 90% of the patient will show VEB abnormalities in the form of delayed latency. And the VEB is highly sensitive for detecting subclinical optic neuritis, where the VEB may show delay even in asymptomatic eyes. And the clinically uninvolved eye also will show abnormal VEB response. And VEB in cases of multiple sclerosis is useful for monitoring disease progression and treatment response. To differentiate between papilledema and papillitis, in papilledema, early in the disease, flash VEB and pattern VEB will be normal in amplitude and latency. But later on, when post-papilledemic optic atrophy develop, both flash and pattern VEB will markedly reduced in amplitude and latency. But papillitis, early in the disease, the flash and pattern VEB will be reduced and significantly delayed. In cases of anterior ischemic optic neuropathy, the predominant abnormality will be amplitude reduction, and the clinically uninvolved eye will have a normal VEB. This 56-year-old male patient with sudden diminution of vision in the left eye due to left ischemic optic neuropathy, the left flash and pattern VEB have marked amplitude reduction with normal to mild increased latency. Also, this is another case of 55 years male patient with right sudden diminution of vision due to anterior ischemic optic neuropathy. Right pattern VEB markedly reduced in amplitude in comparison to the left eye. This patient is not diabetic, not hypertensive, but he has a history of Ozempic intake for 6 weeks, which is a new weight loss medication. Recent studies have suggested that there is a potential link between the new loss medication, Ozempic, and sudden diminution of vision due to anterior ischemic optic neuropathy. But, however, more research is still needed to confirm this direct link. This is a case of 25 years old patient with diminution of vision in the right eye. The right optic disc show temporal disc pallor. He has history of motorcycle accidents. CT show multiple defects in the orbital lateral wall. The right pattern VEB with marked reduced in amplitude and latency in comparison to the left eye. PERG was normal in both eyes, so this confirms that this patient has a right traumatic optic neuropathy. The last case is a 10 years old boy with right diminution of vision due to optic nerve glioma, right pattern VEB with marked reduced in amplitude in comparison to the left eye. In cases of optic nerve glioma, VEB can detect early optic nerve dysfunction and is valuable for monitoring and tracking disease progression in this patient. In conclusion, this is a summary for abnormal VEB in neuroophthalmic disorders. My conclusions, VEB is a valuable tool in diagnosis causes of sudden vision loss, especially when the etiology is unclear, and essential to differentiate between retinal and optic nerve pathology. It can differentiate between organic and non-organic causes, and it can early detect optic nerve dysfunction and can help in monitor of recovery. And thank you so much for your attention.